Well, in fact, for most of us in the academic community, we will get a genetic panel when we do genomic testing on our newly diagnosed melanoma patients. So we virtually always will get NRAS, which of course will be the second most common mutation present in a patient with cutaneous melanoma compared to BRAF. Figure NRAS 15 to 20% of the time, BRAF 45 to 50% of the time. Occasionally, if we have a patient who has rapidly progressive disease and we want to know if they're BRAF mutated, we won't even test for NRAS or anything else. We'll simply send the COBAS test or pyrosequencing or even do immunohistochemistry, which takes 1 day, and forget about the extensive genomic testing. So BRAF is the predominant important genetic test in melanoma because that's really going to determine in the rapidly progressing population with high disease burden, are you going to give them at least an induction cycle of BRAF plus MEK drugs? NRAS would be a secondary consideration for 2 reasons. One, as we know from the NEMO trial, there is evidence that giving a MEK inhibitor alone is better than chemotherapy in the NRAS mutated population. But the problem is, in an era where you have effective combination immunotherapy, MEK drug alone is not going to be your first thought in the NRAS mutated population. So BRAF is what we always think about first. We'll almost always get a genome panel. At my institution, we're at least at 55 genes, including NRAS and BRAF. Other places are getting as many as 500 genes in their panel. But do we test it? Yes. Does it have the importance of BRAF? No.